Okay. All right, so we are recording. Hello, welcome to the second webinar of the Recovery Talk series for the winter quarter. We are here today with Dr. Marienfeld. Very excited that she is willing to come talk to us about opioid pandemic, opioid use disorder, and some medication-assisted treatment for opioid use disorder. So my name is Christine Glissman. My pronouns are she, her. I am one of the health educators in the Health Promotion Services Office, as well as the Collegiate Recovery Coordinator. So with that, we have a lot of different support meetings that run throughout the week for those in recovery or seeking support for recovery. And we also are trying to educate and promote and reduce stigma. So we also have recovery ally training, and then we do some general education webinars, talks, definitely more in the future to kind of just bust the stigma surrounding those in recovery and kind of what recovery means. So with that, I will kind of pass the torch on to our speaker for today. And I will be monitoring the chat and the Q&A, so feel free to jump in at any point and ask questions. I'll kind of monitor those, and then time, depending on the end, I'll get those answered or we'll send them out in an email. All right, I'll pass it on to you.
Great. Well, thank you. Thank you for the invitation. I'm always happy to talk about opioid use disorder and the important things that I think are helpful for us to understand as a country about it. So I'm just opening up the chat here, and then let me put this in full screen mode. Okay, so Christine, if you could just give me a thumbs up that you can actually see the full slides right now. Okay, great. So we will be talking today about some of the epidemiology of the opioid epidemic and opioid use disorder, and we'll understand a little bit more about the rationale and intent of the medications that we use to treat this, and then look a little bit at some of those options. And so, you know, I'm happy to, if you see questions during the time, Christine, that you feel like are relevant or would be helpful, please feel free to just interrupt me, and happy to go off on tangents of all sort, but have some prepared material if people are interested in that as well. So I think it's always really helpful to start with what are we talking about when we're talking about addiction. And this is the definition from the American Society of Addiction Medicine from 2019. And I really like this definition because I think it's comprehensive, where addiction is not just one thing. So when we talk about addiction, it is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. So I like that introduction quite a bit because I think it really helps us understand that it's not one thing. It's not just your brain. It's not just the genetics or what you inherited. It's not just the environment that you're in or the experiences that you've had that contribute. It's really this complex interaction. And because it's so complex, that does make it more difficult to study and sometimes more difficult to treat, but it definitely makes it more interesting. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So ACM put that last sentence in their definition, right? So their definition includes the fact that the treatment efforts are as successful as that of other chronic diseases. And I think that that's really a key point because there's a lot of misunderstanding and misinformation about how people can do when they're struggling with addiction, when in fact they often do just as well as people who struggle with diabetes or high blood pressure or other disorders. So changing gears a little bit, we'll focus on the epidemiology of the opioid crisis. And so in the United States, we really had three waves. Sometimes people say that there's a fourth wave going on right now, but this slide, I think, does a nice presentation of what the three waves are. And so we worry about opioid use disorder, but in particular, the first things that were really making headlines was when we started seeing these spikes in opioid overdose deaths. And so the first wave was really starting in the late 1990s and early 2000s, where we started to see this dramatic increase in prescription opioids, things like oxycodone and hydrocodone. There was a number of reasons for this. And when we saw this increase in availability and use and development of opioid use disorders, we also started seeing increased rates of overdose deaths linked to those particular opioids. Then around 2010 or so, there started to be these quote unquote abuse deterrent formulations that made the oxycodone and hydrocodone harder to misuse. And in doing so, they became more expensive, harder to misuse, and heroin, which was cheaper and more readily available, began to be used more commonly. And so in 2010 is when we really see this sort of sharp uptick in the overdose deaths related to heroin, which has always been present in our society for decades, if not centuries. But that was really, we saw this increase in deaths related to it around 2010. Incidentally, 2010 is when I first started working in a methadone clinic. And so we really did start seeing people who were coming in after overdoses and who were really scared and wanting to get treatment. In 2013, fentanyl started to be introduced into the heroin supply. And fentanyl is a synthetic opioid, unlike heroin, which is derived from poppy seeds. And fentanyl is very potent, and it has a much narrower window. And so it makes for a cheaper product. It's a lot cheaper to ship and distribute from the drug trafficking standpoint. But it's a lot more dangerous in terms of hitting that exact window where you get the high that you want associated with it, but not the risk of overdose and death. And so in 2013 is where we see that sharp uptick in overdose related deaths related to fentanyl. So not all of these are mutually exclusive. Sometimes there's mixtures of substances and various other substances, but it at least gives you the point of where we see these sort of dramatic increases and why I think our country was rightly very concerned about this and tried to divert resources to help. The good news about opioid use disorder, as opposed to some other addictions that people struggle with, is that we actually have medications that are incredibly effective for these populations. However, they have a lot of stigma and there's a lot of barriers to accessing them. So this is looking at some of the increases that we're seeing in the early months of the COVID pandemic. And in 2018, for the first time, we were actually seeing reductions in overdose deaths from all different types of drugs in 2018 for the first time in over a decade or so. But then with the COVID pandemic, we saw a lot of increased isolation. People were cut off from their support networks, from their recovery networks. There was a lot of increase in anxiety and depression, increase in social traumas, domestic violence, drug abuse, et cetera. All of the things that, an increase in poverty, all of the things that can be risk factors for relapse or development of a substance use disorder. And so unfortunately, we started seeing these increased rates of drug overdose deaths in the early months of the COVID pandemic. And then there's been just recently some newer data through the end of the year last year that confirms these unfortunate trends. So this is something called the Substance Abuse and Mental Health Services Administration. Every year they do a survey called the National Survey of Drug Use in Households, or NSDUH. So this is data from 2019. So this is the latest year that we have data available. So this is pre-pandemic data, but it's really helpful at getting a sense for past month use of substances, ever use of substances. And then they also try to get at whether or not somebody meets criteria for having a substance use disorder. So it tries to assess both use and substance use disorders. And then it also looks at mental health. So it's National Survey on Drug Use and Mental Health in Households. So this slide is showing that the big blue circle is that a lot of people have a mental illness, so depression, anxiety, schizophrenia, bipolar disorder. The green circle are the people with the substance use disorders. So that's a lot of people, 20 million people. And then the 10 million of people in the middle have both. And so it's really a large population that has both. And so oftentimes it's important to not ignore the other ones. If you don't treat the substance use disorder and you're trying to address the depression, you're not going to get very far. And if you're not addressing, let's say, the alcohol use disorder, and you're sorry, if you're not addressing depression and you're trying to treat the alcohol disorder, you may not get that far, right? So oftentimes treating both, the outcomes are much better. So this is looking more specifically on prescription pain relievers. So certainly fentanyl gets a lot of headlines, as does heroin. But we still have a large proportion of people in this country who struggle with prescription pain relievers, whether they're prescribed them or they attain them illicitly. There's still quite a large number of people who have these different prescription, either prescriptions or use of these things. And so while we're seeing some modest decline in users over the time, which is good, up into 2019, and again, that was pre-pandemic, we still need to pay attention to heroin and fentanyl because of their high risk of overdose. But we also need to not forget about these other opioids that can cause problems for people as well, because there's a lot of people who use them. So again, this is just looking at the differences, and really we were seeing some positive trends in 2019. So if you break it apart by age categories, this is looking at opioid misuse amongst 12 to 17-year-olds. We had seen a dramatic decrease. In 18 to 25-year-olds, we had seen some significant decrease. The stars mean that it was significantly different. Even in adults and the whole population, we really did see some minor decreases, again, for the first time in years. That was really promising. And this is just looking at prescription pain reliever amounts versus heroin, and just seeing again that we were seeing fewer people initiating with heroin in 2019, which was really a positive sign. So this is not just looking at past year or past month misuse, but actually looking at opioid use disorder itself. So not just looking at use, but actually whether or not somebody meets criteria for having a problem. And so I have a slide later where I'll talk to you about the criteria that we use for how we make a decision about whether or not somebody has a problem or if they just have use. A lot of people are exposed to opioids. If you have a surgery or broke a leg or whatever, there's a lot of reasons people are exposed, and most of those people don't go on to develop a problem. But the more number of times you're exposed, for the longer duration you're exposed, the more likely you are to develop a problem with the substance. So this is, again, looking at not just misuse, but people who have an opioid use disorder, which is why the numbers are smaller. But again, in 2019, we were seeing all these promising signs of decreases. So this is looking at also, while we were seeing fewer people initiating, we were also making really great strides in terms of the number of people who are on the various treatments that we have for opioid use disorder. So the three main treatments that I'll talk about a little bit later include methadone, buprenorphine, and naltrexone, and I'll talk about what those are. But overall, we were seeing that more people were having, ideally were having access to it, or were somehow able to access it and utilize those treatments than in the past. And so these treatments are well documented to help prevent and reduce opioid overdose deaths. And so as we see, there's a correspondence between increasing in use of the medications for opioid use disorder and decreasing the deaths. So how did we get here? So this is one of the reasons that we got here. This is the Universal Pain Assessment Tool. And this was starting in the late 1980s or early 1980s, really, where there was this concern that doctors were undertreating pain. They weren't asking about pain. There was this whole movement to make pain the fifth vital sign and to always ask about it. Well, if you ask about it and somebody's in pain, then you should probably do something about it, right? And so what ended up happening is that there was a lot of marketing and other things that opioids were safe, that doctors were underutilizing them, et cetera, to where they ended up having it. This is Russell Portnoy. He's one of the early champions of high dose opioid use, although he's since changed his position on that. The American Pain Society said pain was the fifth vital sign and needed to be addressed. And we just really saw this dramatic increase in opioid prescriptions. And so there were a lot of opioids out there and a lot more exposures. And because they were being prescribed by physicians, people were either unaware or just sort of minimizing the risk. There's all kinds of books and all kinds of things, New York Times articles, et cetera, where you can read about The drug companies that marketed these as safe, knowing that that was not in fact the case, and misrepresenting data and overgeneralizing it to populations it wasn't intended for, et cetera, et cetera. So as an example, Purdue Pharma, the makers of Oxycontin, when Oxycontin was first released in 1996, it had $48 million in sales. And 4 years later, by 2000, with all of its marketing, et cetera, it was making over $1 billion in sales. And in 2004, it was the most abused drug in the United States. And they had these huge, massive sales force teams, et cetera, et cetera, et cetera. So it's a much longer story of how we got here. It's a very interesting story, but I'm going to shift gears and talk a little bit more about what we can do about it now. So I've just mentioned the term opioid a number of times, but I think it's helpful to remember what an opioid is. So an opioid is any substance that acts on the brain's opioid receptors, right? So we have our body's own endogenous opioids, things like beta endorphins, dynorphins. So our body makes its own opioids, and that's why we have opioid receptors. And so our bodies regulate things, food, sex drive, et cetera, with our own endogenous opioids. There are things called opiates, which are derivatives from the poppy plant. So things like morphine, heroin, codeine, they're naturally derived. They're structurally similar to each other, and they act on that same opioid receptor, although in a more potent and slightly different way than our body's own endogenous opioids do. We have synthetic opioids, things like fentanyl, buprenorphine. So these are structurally different. Their chemical structure is different, but they still can act on that opioid receptor. And most of the prescription opioid pain meds are synthetics or semi-synthetics. So things like oxycodone, hydrocodone, et cetera. Sometimes you hear the term narcotic used a lot. Some people use it to mean opioids. It's technically more of a legal term than a medical one, and it means illegal use of any controlled psychoactive substance. So that's a pretty broad category. So narcotics includes a lot of things like opioids, but it means other substances as well. So addiction is a complex and chronic disease. So this is an interesting model of addiction. And this has been around for a while, and this is applied for alcohol, for opioids, et cetera. And it shows what is the sort of phases that we think of when somebody develops addiction and the underlying brain structures and regions that are most likely linked and related to those particular processes. So at first, when somebody starts using a substance, they, typically the idea is that they use it because it makes them feel good, or it takes away negative feelings, right? So the idea that you get high or that you feel, calmer, happier, etc. And this is mediated through the basal ganglia, which is part of the brain. And this is called the binge intoxication phase. And there's something called incentive salience. That's where it's incentivizing. There's meaningful, you get incentives when you do it. You feel good when you do it. And this is followed by the withdrawal negative affect phase. And we see this particularly with opioids, where after you feel good for a little while, then you feel really, really bad. And your brain really, really wants it. And so this is associated with the extended amygdala. And this is where people spend the majority of their time in the addiction cycle, is really in this, like, I feel worse after the good part. And this can be influenced by things like your genetics, your epigenetics, childhood trauma, psychiatric comorbidities, et cetera. And there's this sort of negative state called hypercataphea that they talk about, where you don't get the rewards associated with the substance, and the stressful things are sort of exacerbated. So if you're in this terrible, yucky, negative feeling, then we progress to something called the preoccupation anticipation phase, or craving, where the person really wants to use the substance again to feel better. And so this is mediated by the prefrontal cortex of the brain, which is involved in a lot of what we call executive functioning, things like planning, making decisions, impulse control, delayed gratification. All of those kinds of things are in the prefrontal cortex. And so when you're craving, those things aren't on board to help you in the same way. And so what ends up happening is that theoretically this is a cycle, but then most people end up spending a lot of time in the negative phase. So when we're trying to make a diagnosis of an opioid use disorder, we have criteria from something called the DSM-5. That's the manual that psychiatrists and behavioral health and mental health professionals use. It's called the Diagnostic and Statistical Manual. It's in its 5th version that came out in 2013. And it has 11 criteria that we use to determine whether or not somebody has transitioned from opioid use to an opioid use disorder. And this isn't, an exhaustive list of everything that could ever go wrong for somebody with a substance use disorder, but it's a good list to try to kind of go through. And in fact, when you kind of run through this with patients who previously might have said, oh, it's not a problem at all, there's no problem. When you kind of just ask them about these different areas, then they sort of recognize, well, maybe it is causing some problems in these areas. So you have to have 2 or more symptoms in the same 12-month period. For opioids, it can't just be tolerance and withdrawal, right? So if you're being prescribed an opioid for pain, you will develop tolerance to it, and you will probably have some physical withdrawal when you stop it. So that in and of itself is not sufficient. Those are the pharmacologic properties. But we also think about risky use, where people are using it in hazardous situations. So if your opioid use is out of control, you're using it while you're driving, it's causing you to fall down stairs, et cetera. If you're passing out from use and putting yourself at risk for passing out in dangerous situations, that's hazardous use, and that's a sign that it's gotten out of control. In addition, people who use substances continually for long periods of time often have much higher rates of anxiety and depression. They're more at risk for physical problems. So like with alcohol, you might be putting your liver at risk. With opioids, if you're injecting, for example, you might be at risk for thrombophlebitis or endocarditis, where you inject, or hepatitis C, where you inject bacteria and viruses into your body. So continuing to use, despite having any physical or psychiatric problems that are worsening because of your use, is also a sign of risky use. Then we think a little bit about impaired control, right? So it becomes a disorder when we lose control over the normal limits that we would have for it. So if you find yourself using more than you intended to, or for a longer period of time than you intended to, sort of saying, I'm only just going to have one, or I'm just going to go out for 30 minutes with my friends and then I'm going to come back, but then not sticking to your goals for yourself, that's part of a sign of loss of control. If you spend the vast majority of your day using, obtaining, or trying to recover from the substance, if it's really sort of taking over, that's a sign of loss of control. If you're trying to cut down and you just can't seem to be able to do it, so repeated unsuccessful efforts to quit or cut back is a sign of loss of control. And then actually craving, right? So when your body is constantly thinking about it, your mind is constantly thinking about it, wanting, you're trying to do your normal activities and your mind just keeps going back to it. That's also a sign of losing control over the use. And then we think about the social impairment, or the way that the substances impact our lives and our functioning. So are you not able to do your major role obligations at work, school, or home? Are you giving up important activities that you would otherwise do in order to use instead? Or is your substance use causing problems with friends and family, right? Are they worried about you, or are you picking fights when you're intoxicated, et cetera? So these are just a handful of the ways that we think about when we're thinking about, is this a problem and do we want to make a diagnosis? So as I've mentioned earlier, opioid use disorder is a disease, and similarly to diabetes, high blood pressure, et cetera, it's biologically mediated. So we understand a lot more about the brain and how it's biologically mediated. It's psychologically mediated. So our personality traits, our mental health, all of those things impact our likelihood to develop a substance use problem. Psychologically mediated can also mean like things like impulsivity traits or sensation seeking traits that are studied a lot, can predispose somebody to relapse or development of a problem. It's certainly socially mediated, wherein the environment that you're in and what people do around you affects your behavior. It's similar to other diseases where lifestyle changes may help improve it. So a lot of times in recovery, people build in exercise, they build in, support networks, things like that. So how, healthy eating can improve your risk for relapse or problems. The symptoms are often relapsing and remitting, just like with high blood pressure and diabetes, where we see that. And meds may be necessary for life. So we always wish that, things were like surgery where you just cut out the bad part and everything's fine again. But for most people, these are chronic diseases that they struggle with lifetime. And so while of course it would be ideal to just have a quick fix medication that took everything away, for the most part, people end up being on them long term and they continue to do well. And the outcomes continue to improve the longer they're on the medications. And so if you look at the graph there on the right, this is a comparison of relapse rates between people with drug addiction and other chronic illnesses in terms of relapse when they're not taking their meds and, if their diabetes, blood sugar is high, et cetera. So opioid use disorder has some long-term risks that impact our lives. So in addition to the risk of overdose, which we already mentioned, they're at higher risk for suicide, higher risk of being both a perpetrator and a victim of violence, much higher risk of accidents. People who end up with opioid use disorder at higher rates of, higher risk of doing crime in order to pay for their substances. Certainly affects relationships and social functioning. In particular with opioids, we often worry about transition to IV drug use and infection risk associated with that, including HIV and hepatitis C. And of course, the psychological effects. So as I mentioned earlier, we see increasing rates of depression, anxiety, et cetera. So what tends to happen in opioid use disorder, and I think that we kind of hinted at this with that slide earlier with the brain and the circles around it, is early on people start using because it feels good. Not everybody likes opioids. Some people use it and they get nauseated or they don't like them. But for a lot of people who end up developing a problem, the first time they use them, they feel energized, they feel high, they feel good. And that really drives the initial use. And then over time, we see this transition. And if you talk to people who've had long-term opioid use, they'll say, like, I don't even feel that high anymore. I'm just using to prevent withdrawal and just using to feel normal. And so we see this transition to use to try to avoid and prevent withdrawal. And it becomes this cycle where you have to use pretty often to avoid that. And so what we do with the medication treatments for opioid use disorder is the idea is to take away this constant cycling between withdrawal and feeling normal and put somebody at a steady state level with a low level of a safer opioid that helps to keep them at a normal level where they're not in withdrawal and they're not feeling any kind of high or euphoria. So what's so bad about opioid withdrawal? It's a pretty negative experience, right? So people, their heart's racing, they've got goosebumps, they have pretty terrible nausea and vomiting. They're having to urinate a lot, they get diarrhea. It's very, very painful. So people often assume that the pain that they get from opioid withdrawal is because of whatever underlying the pain they may have had. But actually for people who've never had pain, opioid withdrawal is very painful. Muscle cramps, what they call this like break bone pain. It's really painful, miserable, stomach cramping, et cetera, kind of experience. And so that's what often drives people to do things they never thought they were capable of in order to avoid feeling this all the time. So why don't we just get the opioids out of people's system and then send them on their way? And the answer to that is that if you just detox somebody, the risks of relapse are incredibly high. So this is, just one study of patients coming out of detox. And so coming out of detox within one day already, like 25% of people had relapsed within one day of coming out of detox. And within 30 days, there was only about, under 20% or so who had not relapsed. So the relapse rates are incredibly high. There are people who can stop opioids, and I think it's in that 15-20% range of people who come off the medications, who come off opioids, who can maintain abstinence and do fine. And so it's not that it's impossible to do that, but study after study, it's kind of in that 15-20% range of people who are successful long-term without some of the other supports. So as I mentioned, we've had detox for a long time. We've had residential or rehab programs for a long time. We've had a lot of community-based support programs, AA, NA, Smart Recovery. There were these experimental pros and cons kinds of groups with therapeutic communities and other things like that occurred. But the challenge with opioids is that, the relapse rates were just really, really high. And so that's why we have a new way of thinking, where we really started thinking about, are there medications that we can use that are much safer than the opioids of abuse, but that end up actually preventing a lot of these harms that we think of when we think of it. Some of the older terminology was medication-assisted treatment, or MAT, so you might still hear that. Sorry, this is like my third lecture for today, so I'm losing my voice. So you might see this terminology MAT around. I don't like it, and I think the reason why it's gone out of favor is because we don't say like medication-assisted diabetes treatment, right? Your insulin is just part of your diabetes treatment. So it's not medication-assisted treatment, it's part of the treatment. Or some of the newer terminology we see now is MOUDs, the medications for opioid use disorder. And the other thing about that is that it includes not just opioid agonist medications, which I'll explain what that means, but it also includes opioid antagonist medications that we also have that are available that can help people. So as I mentioned, we do have behavioral therapies that are very, very helpful for people. So we still do lots of cognitive behavioral therapy. We do things called motivational interviewing, relapse prevention, etc. So there's a number of behavioral therapies that are really helpful for making a recovery plan and for helping people engage in a recovery lifestyle. But since the focus of this talk is on meds, I'll focus on that. And then we do have 3 FDA-approved medications for opioid use disorder: Methadone, Buprenorphine, and Naltrexone. So the medications, the MAT or the MOUDs, are really used because they prevent morbidity and promote recovery. So in these studies, for example, we see reductions in injection and illicit drug use. So daily use going from 70% on treatment admission to 16%, which is pretty dramatic. We don't see numbers like that in medicine very often. In psychiatry, certainly not. I wish that I could say that antidepressants work that well, but they certainly don't. But even for things like blood pressure or, and which isn't to say that antidepressants don't help some people, they do, but they don't help everybody. And I wish that, I wish that we had a magic pill that would help everybody. But even for things like blood pressure, other things, to see one medication trial have that level of effect is just, it's really rare. We see increased rates of abstinence. We see promotion of return to work and family obligations. So when patients get on treatment, the unemployment levels go down. There's a number of studies showing decreased risk of transmission of HIV and hepatitis C in IV drug users when they're offered access to and able to use methadone and buprenorphine. So HIV seroconversion, which is when you become HIV positive, decreases by upwards of 85% due to the reduction in IV drug use. We see reduced bacterial infections, reduced criminal behavior, improved relationships. I could go on and on. All right. They also lower the overdose risk. So for people who are in non-medication treatments for opioid use disorder versus those who are on meds, they have an 80% lower hazard ratio of overdose deaths during the time that they're on the medications. And the risk of fatal overdose significantly increases in the weeks when patients are discharged or when their medications are stopped. And so we see this a lot where patients do well with buprenorphine, for example, but feel like they want to get off of it. They don't want to be on it for a lifetime. And unfortunately, in that period of those few months after somebody comes off, the risk of overdose is very high. So I mentioned opioid overdose. So we do have something that works really well to treat opioid overdose. It's called naloxone. It's an opioid receptor antagonist. So that means it blocks the activity of the receptor when it binds to it. So the naloxone comes on, it'll kick the opioid off the receptor, bind to it, and stop the action of the opioids. It's relatively short acting, so if you ever need to administer this for any reason, You do still need to seek medical attention, put the person in the recovery position where you put them on their side. So if they start vomiting and things like that, they don't choke on their own vomit. And you still want to call 911 and make sure that they get medical attention, because if there's still opioids in their system and then naloxone starts dissociating from the receptor, then somebody can overdose again. Naloxone, there's a lot of attempt to make sure that first responders have this and that lay people have this. We give out lots of prescriptions for this, and hopefully my patients never need it for themselves, but a lot of them end up using it on people around them who are still using or things like that. So the goals of our treatment, ideally we want to catch it early where it's easier to treat. We want to decrease any kind of withdrawal symptoms that make them feel uncomfortable. Ideally, we eliminate any cravings or any desire to use opioids, because those cravings are such a huge driver of relapse. We certainly want to prevent relapse, and we want to improve health and overall functioning. So if we had a perfect medication, ideally it would not be IV because that certainly increases overdose risk as well as infection risk. The reason we typically recommend oral medications is that they're slower in onset, so you don't feel as high from them because of that slow onset. And then once you get tolerant to it, you shouldn't feel any kind of high or euphoria. Ideally, it's once daily dosing or even less frequently than that, right? So you don't have these multiple cycles of intoxication and withdrawal that you're going through every day. Ideally, they don't make you feel high or have any kind of cognitive impairments or side effects. And of course, it would be legal. So we don't have a perfect medication, but the medications that we do have available are a pretty good approximation for this ideal list. And the idea behind them is something called harm reduction. So harm reduction is this approach where it would be great if nobody ever injected opioids. But since we know that does happen, we try to find ways to prevent that from happening and being worse. And so, it would be great if we didn't need to give opioids to people, but it's by far one of the most effective ways at preventing a lot of the harms that we see with patients who are using, including being high, being in withdrawal, needing to use often, criminal activity, etc. So I mentioned these terms earlier, agonists and partial agonists and antagonists. So an agonist is any substance that binds to a receptor in the brain and causes a biological response. And we have partial agonists, which binds to the receptor and causes a partial response, or we have a full agonist that'll bind to the receptor and cause a full response. And then we also have antagonists, and antagonists block the receptor or cause no response. So agonists include the substances that people often misuse, like heroin, oxycodone, fentanyl. But methadone, which we use to treat this, is also a full opioid agonist at something called the mu-opioid receptor. And when methadone is in your system and bound to that receptor, if you try to use heroin or oxycodone on top of it, it doesn't let it bind. And so you don't, when you have a steady level of methadone in your system, you can't really get high on top of it. And you actually end up getting cross tolerance, which is partly how it prevents overdose deaths with it. Buprenorphine is something called a partial agonist. And so and I'll show a figure of what that means in a moment. And then the naltrexone or naloxone that we mentioned earlier are the antagonists. So this is the opioid overdose reversal agents. So if you have the naloxone, the antagonist, you give more and more and more of it and you get no effect on the receptor. If you have a full agonist like methadone, you give more and more and more and more of it, or heroin or fentanyl, you give more and more and more of it, and eventually you'll have more and more and more effect until the person dies from stopping breathing, which is the cause of death in opioids. With the partial agonists like buprenorphine, and the reason why buprenorphine is a little bit more accessible is because it is somewhat safer in the sense that you give a little bit of it, you get more effect, you give a little more, you get a lower effect, until you get what's called a ceiling effect, where you can give more and more of it and you don't keep getting any additional effect. So it's not impossible to overdose with buprenorphine, particularly if you combine it with alcohol or benzodiazepines, but it's much safer than the full agonist opioids for overdose. So the challenge with buprenorphine is that if you have the full agonist like heroin in your system and you give buprenorphine, which is a partial agonist, you go from that fully activated state into the lower state, and people feel that as withdrawal. And so this is why it can be a challenge to start buprenorphine for patients sometimes, where that partial agonism, you want the person to already be in withdrawal so that then when you start the medication, they feel better. Whereas if you give it to them when they've recently used other substances, they feel worse. And so there's a lot of people who've used buprenorphine trying to treat their own substance use or et cetera, and have run into this problem and ended up experiencing this on their own in a not pleasant way. So methadone has been around for a while. It's regulated by SAMHSA. It's only given in a specialty treatment program called an OTP, or an opioid treatment program. A lot of research was done on methadone in the 1960s in New York, and for example, in Vietnam veterans coming back from Vietnam who had been exposed to morphine and opium and heroin, although certainly there were people using heroin in US large cities, in addition to veterans as well. So it was legalized literally through an act of Congress in the early 1970s. Buprenorphine has been around again since the 1970s as a pain medication, but it was legalized for the treatment of opioid use disorder, again, by an act of Congress in 2000, and then available in 2002. Providers do have to have a special license and a certification in order to use buprenorphine, but you don't have to give it in a specialty treatment program. So any provider who has the special license can prescribe it. Naltrexone was approved as an injectable form for opioid use disorder in 2010. It's a once monthly injection. You don't have to give it in a special clinic. You don't have to have a special license. So it has some advantages for that reason. So how long should you stay on these medications? So there was a study that compared outcomes for patients who were on it for 6 to 9 months, 9 to 12, 12 to 15, 15 to 18. And the patients who were on it longer were much less likely to be seen in an emergency department, to be hospitalized, to receive another prescription for an opioid analgesic, et cetera. And then there's another study looking at the UK where people who took buprenorphine for at least 2 years had much better chances of then being able to successfully decrease and come off of it versus people who tried to come off of it earlier. So there's no magic answer as to how long people should stay on these meds, but typically we recommend that they have a lot more stability in their life, that they have a pretty good recovery plan, that they're not being exposed to substances. And then we try to just come down very, very slowly. And by slowly, I mean, over a year, not over like a few weeks. And then people do, are able to come off, and some do quite well. But it's, but the answer is, as long as it's helping, we stay on it. So again, why not just, have them come off medications and just stop taking them and not, just say no to the drugs. So what are we asking of people when we ask that? We are asking people to exert an athletic level of discipline and sustained determination without much training or experience in behavioral self-control that is fully counter to their neurobiological drives, and often supported only by fear incentives, the loss of work, relationships, or health. We know that fear incentives may be effective in the short term and in terms of crisis, right? So they can be pretty effective at short term. But positive incentives, such as having a sense of purpose, financial security, meaningful work, meaningful relationships, avoid the natural fatigue of sustaining long-term recovery from substance use disorders. We know this time and time again. Punishments, negative incentives, they work really well in the acute setting towards behavior change. But if you want to maintain things, the things that people gain as benefits are what sustain it, whether that's positive relationships, better mental health, all of those things that they gain. So recovery capital is an important consideration as well in terms of when people do well, and whether they're taking medications or not. Having social supports, friends who don't use substances, having a sense of meaning in their lives, or finding a sense of meaning for their lives, having some sense of spirituality in their daily life can be protective. People who are affiliated with recovery networks who have a good peer cohort do better. and that may be provided with some of those kinds of things. So recovery capital is an important concept of the things that aren't necessarily based on the underlying biology per se, but really do allow people to do better. So I can go through a little bit more of the specifics of the specific meds if we want to. So naltrexone, it sounds like a great idea, and in many ways, it's really a good option for many people. It's an opioid antagonist, so it blocks the effects. The challenge with it is it's really hard to get it started in a lot of people because you have to have at least 7 to 10 days without opioid use. Even that's a little bit conservative sometimes, depending on what the person was using and how much of it's still in their system. So actually getting started with it can be a challenge, but for patients who do end up successfully starting naltrexone, it does help with cravings, and they do seem to do well with it. Methadone, I mentioned already, methadone is delivered in an opioid treatment program. It decreases craving, it decreases high and overdose risk. It does have some side effects. It is an opioid, so people report a lot of sweating, sedation, constipation with it. The sedation tends to get better over time as your body gets tolerant to it. It can lead to something called QTC prolongation. So several opioids have this, where at higher doses, they can put you at risk for arrhythmias. And so that's something to be concerned with in somebody who has any kind of cardiac history in particular. But it lasts a long time. People are able to take it once a day. And most people who take it and stabilize on it really do much better with it. There's actually better retention in treatment with methadone versus all of the other options. And retention in treatment long-term is linked to other better outcomes. There's a lot of stigma associated with methadone, unfortunately. It's often provided in clinics that aren't always in the best neighborhoods. There's a challenge because you have to go to the clinic every single day to get it until you earn take-home privileges. And so that's a huge hassle if you have kids, if you have to work, et cetera. So there's a number of barriers there. It's the most studied of the 3 medications by far. It's one of the most studied medications of all time. If you look at like single medications and the number of trials. Retention and treatment, as I mentioned, is really much higher here, and that's really a critical piece of it. As the dose increases, so does the retention and treatment. Most dose range seems to be 60 to 120 milligrams, although we see a wide range. We do have to be careful with this medication. You have to start it at a lower dose and increase it slowly because of some things that are particular to it, to that particular medication. But we see pretty clearly, so as the dose of methadone gets into the ranges where we see people doing well, you see that the percent of people who are showing positive heroin use decreases dramatically. And then the challenge, as I mentioned before, is that in patients who come off of treatment or who come off of treatment early, this is looking at patients stopping methadone maintenance and relapsing to IV drug use. And you see, within a year, about 80% of them have relapsed. So it's not 100%. Like I said, there's that 10 to 20% of patients that can do okay and come off of the meds and may not need them. But many people, if they come off early, they have a pretty high rate of relapse. So buprenorphine, as I mentioned, it's a take-home medication. It's a partial opioid. It helps decrease the cravings, the high, the overdose risk. It doesn't have the QT prolongation and some of the other risks that methadone does. It's still an opioid, so patients do complain of constipation and sweating with it. Some patients find it helpful where they split up the dose and take it for pain relief, and some of the analgesic effects actually work better at lower doses. But the analgesic effects of both methadone and buprenorphine don't last that long. So if you're taking it for those reasons, then you need to take it more frequently. It comes in a bunch of different formulations. So we do a lot of the once monthly injectable versions up at the top. And then most of our patients take the films, but it comes in tablets. There used to be these implants available, but there's no more. Those came off the market, but there's a number of different brands, et cetera. So in summary, naltrexone really is for people with long-term treatment, and for oral naltrexone, when people take it by mouth, it doesn't really seem to help prevent cravings or risk for relapse. But the once monthly injectable naltrexone does help to prevent cravings, and has been shown to be very effective if you can get patients started on it, which is a challenge sometimes. Methadone and buprenorphine have similar outcomes. So common misperceptions that patients are just using these meds to get high. If patients have really almost no tolerance for buprenorphine or methadone, with their first few doses, they can feel a little bit of a euphoria with it. But the idea is that they take them consistently and then they don't really feel any kind of euphoria because they develop tolerance from it. That the med is just another drug. I hope that I've presented the case that it's actually a carefully selected medication that tries to minimize the problems that we see with drugs of abuse. Tapering off medication sooner is better. I wish this was the case, but unfortunately, patients tend to do better with longer term use. And another common misperception is that medications are a panacea, when in fact, people still have underlying psychiatric problems, social problems, other drug problems, etc. And so one medication can't fix all of those things, and we still need to make sure that we pay attention to the other stuff. So we just want to be careful about the language and things like that we use. So we don't say, opioid abuse. We don't say opioid addict. Those tend to have derogatory associations associated. We use the term opioid use disorder. We don't say addict. We say a person who takes opioids. We don't say an IV drug user. We say a person who injects drugs. Language can, impact the stigma and how we think about these things quite a bit. So with that, thank you. If you're willing to just shoot your little camera phone on the QR code, it is helpful for faculty to have evaluations on our file for promotion and things like that. So if you guys are willing to do that, that would be appreciated. And with that, I'm happy to take any questions.
Yes, thank you. That was great. I always appreciate all the science because I think that really helps break down the stigma, sort of describing all the intricacies that sort of are involved. So I really appreciate that. I think I also really appreciate that just no slide, really talking about how punishment or any of that sort of like negative reinforcement doesn't work. And that really it is sort of, it's not just becoming sober, but it is purpose driven. It's finding those good relationships. So I think I really value that was incorporated. So thank you for that.
More of that. If you look up like gain frame psychology, like so framing things based on what you gain.
I love that. Yeah.
Yeah, that's what you can see more things there. But I love that quote too. It was just like a random sentence in a paper. And I just thought it was so well done that I made it into that slide.
Yes.
Yeah.
Do we have any other questions? We've got a couple minutes here. If they don't get answered, I can always send the questions and kind of give the answers out to the group. But any questions or any thoughts from anyone? So we have one. So thank you for a great presentation. Would you mind giving your opinion on the current X waiver issue?
Wayne, yes. I actually am a little stodgy on this because I recognize the concerns about the X waiver. So he's talking about the license, the special license you need to prescribe buprenorphine. So the arguments are any physician can prescribe opioids. Why do you need a special license to prescribe the treatment for opioids? And I totally get that. The other argument is that there's not nearly enough physicians who will prescribe it. There's not nearly enough access to treatment, particularly in rural areas, et cetera. The concern I have is right now is that we're having this huge blurred line with patients with chronic pain and opioid use disorders. And it's getting really murky in terms of like, what are we treating? Is this a problem? Is this not a problem? I think prescribers are using buprenorphine a lot for, like the patient thinks they're taking it for pain. The prescriber thinks they're taking it for an opioid use disorder. Nobody's having like an honest discussion about what we actually think is going on here and what we're trying to treat and what our goals are for helping. So I don't know that the waiver actually totally fixes that, but I think when you have the waiver, it at least gives the you're at least clearly in the realm of, I'm prescribing this for an opioid use disorder, and we have to talk about, what does that mean? You know, are the opioids causing problems in your life? And if they are, then we need to address that, right? Because opioids are powerful medications and they cause problems for a lot of people. So, you know, I'm not totally in favor of having to have the waiver, but I think that we need to, if we just eliminate the waiver and we don't have these conversations, I worry that we're actually not going to be providing very good care for a lot of people.
Mhm. And we have one more question. Do you have a couple minutes? I know it's 2.
It's okay. Yeah.
Okay.
I do have another Zoom, but I can answer this one question. So the support groups for friends and families. There's a NAABT, which I forget exactly what that stands for, but it's like a national association. I don't know. It's got a lot of good resources that are, you know, helpful. But any of the SAMHSA, the Substance Abuse Mental Health Services Administration, NIDA, any of those kinds of things that have patient family resources, those are all evidence-based pro, you know, data for using meds. So all of those things that have patient referral resources and stuff like that are helpful. But that other one, it's like naabt.org, has a lot of really good stuff for helping connect people and how do you talk to your family about methadone. Another good one is, so Addiction Treatment Forum is a really good one for sort of lay people stuff. And they have a lot of like handouts and stuff, like how do you talk to your family about methadone and stuff. And then there's another one, it's not just Addiction Treatment Forum, I'm blanking on what it's called. Anyway, yeah, there's a couple of ones like that I would look into.
Okay. Well, thank you so much. I greatly appreciate you talking with us, and excited to continue this relationship, get to know you more, and kind of your work as well. So thank you for being a support.
Yep, happy to do it. Thanks, guys.
All right, thank you.